Overview of my presentation. For the next 15 to 20 minutes, I'll be touching base with the various entities under myeloproliferative neoplasms, a brief note on the pathobiology of this entity, a little bit about the driver mutations, and talking finally about the triple negative MPN and our experience with this thing. This is the slide showing the latest classification of myeloproliferative neoplasms. As you all know, myeloproliferative neoplasms are a group of related clonal hematological disorders characterized by the accumulation of one or more myeloid lineage cells. And the deregulated JAK2 is the central pathogenic mechanism here. As you can see, the BCR-ABL negative group comprises of polycythemia vera, primary myelofibrosis, essential thrombocythemia, chronic neutrophilic leukemia, MPN, NOS, and CEL. Among these, the ones that are highlighted in the red are considered as the classic MPN, and the last three are the non-classic MPN. And the latest entrant to this group is the juvenile myelomonocytic leukemia. While deregulated JAK2 is the key pathogenic mechanism, the three driver mutations belong to JAK2, CALR, and MPL. So this is a very brief representation of the pathobiology of myeloid neoplasms. And as you can see, it is a spectrum ranging from one end where there is myeloproliferation, that is without any change, it's a differentiation, it's just an excessive accumulation, while the other end has dysplastic features and various other entities which are an overlapping phenotype. I will not be talking about this group. The focus of this presentation would be MPN and the triple negative entity, like I'll talk to you about. So what are the origins of this description of the molecular mechanism? Though the myeloproliferative neoplasms were described in 1800s. It was only in late 1900s that the JAK2 was cloned, and that JAK2 V617F was associated with MPN in 2005 by 4 groups simultaneously. And then MPL was called the as a driver mutation associated with MPN in 2008, followed by CALR as having a putative driver mutation in MPN in 2015. So reiterating the fact that JAK-STAT is the key aberrant mechanism here, 90% of these are mediated by somatic mutations involving cytokine receptors or their downstream pathway. V617 was the first mutation, and this comprises more than 95% of PV cases. Approximately 50 to 60% of ET and PMF have this. MPL mutations comprise 5 to 10% of ET and PMF, 25 to 30% of CALR mutations. So this slide is a very quick representation of these cytokine receptors, that is the JAK2. To the left side, you see the JAK2 the gene with the different functional domains, and 617 is present in the pseudokinase, and because of this mutation, there is a constitutional activation of the JAK2, resulting in excessive proliferation of cells downstream. And here it is the exon 12, which has a similar effect, and this is known is a known mechanism of action in very few cases of V617F negative PV. Lastly, this is another cytokine receptor, like I have told you, MPL, and the hotspot region is in the exon 10. Now, how did this come about? Like the previous papers, they have done research and shown that these are the hotspot regions in both JAK2 and MPL. CALR is the third one. Though this is not a cytokine receptor, this is a molecule with chaperone activity, and these are the various functional domains, as you can see here. And what actually happens is the mutation changes the charge from a negative charge to a positive charge that is critical in allowing CALR to bind with MPL and then regulate the downstream signaling. So based on all these studies, and that only hotspots are involved in the pathogenesis. The conventional methods included allele-specific PCR to identify the V617 or the MPL mutations, and to screen for the various mutations in the exon 12, Sanger sequencing is done, and fragment analysis plus Sanger sequencing is done for CALA. These are the conventional methods. Why am I talking about these conventional methods? Because that's where triple negative entity comes, and this is defined as individuals with no mutation detected in common screening tests for variants in JAK2, CALR, or MPL. So essentially, it's a molecular entity. However, the patients present or exhibit histological and phenotypic features that is sufficient for a diagnosis of MPN. As you can see here, all the studies that have done extensive testing, for example, a whole genome or a whole exome sequencing, have identified non-canonical mutations in MPL and JAK2. And this is the representation of different mutations that were described, which are not present in exon 10 or some other exons, and in JAK2, which is apart from the regular exon 12 and 14. So in what percentage of ET and PMF do we see this? Around 10 to 20% of ET, 5 to 10% of PMF. Essentially, as a disease, triple negative ET is an indolent disease with low incidence of vascular events. Triple negative PMF is an aggressive disease with myelodysplastic phenotype and a high risk of leukemia transformation. Note on the different genomic studies that were done elucidating the landscape of MPN. This is a seminal paper by the Campbell group in 2018 that studied 2,035 patients of MPN and described 16 myeloid genes, of which 45% were driver mutations. And this is a pictorial representation just showing the different groups that are important in myeloid neoplasms, where somatic mutations have both diagnostic and prognostic effect. Some of them are growth factor receptors, cytokine receptors, ubiquitination, proteasome complex, cohesin complex, then transcription factors, etc. So based on all these papers and based on all the genomic studies, the WHO 2016 recommends that a clonal marker is included as a minor criterion in ET and as an alternative major criterion in PMF. And essentially to say that when all the three driver genes, mutations in the three driver genes are negative, we have to screen for further evidence of clonality. ASXL1, EZH2, TET2, IDH12, SRSF2, SF3B1 are the key genes that are described as guidelines under WHO. So ultimately, it boils down to a wider search area using techniques such as whole genome or targeted exome. And more so in triple negative PMF, it is important because this group has an inferior leukemia-free survival compared to the group that has mutations in the driver genes. So what is our experience from CMC Vellore? Before we went ahead characterizing the triple negative group, we cleaned out all the cases that were sent for the MPN panel and had a clean cohort of 407 patients and described the driver mutations in each of these entities, the polycythemia vera with only V617 and exon 12, ET, PMF and MPNU. The ones highlighted are the triple negative group. This is 26%, which is slightly higher than what is reported elsewhere in the world. Triple negative PMF and MPNU. So this was the algorithm. From the beginning, like when the MPN group was characterized, this was the algorithm that was followed with the clinical features of MPN, then the basic diagnostics of peripheral smear bone marrow morphology, including collagen reticulin grading, conventional karyotyping FISH for BCR-ABL to clearly exclude out pH negative MPN. And we look at classic MPN here, follow reflex testing of these driver mutations, and then only select the ones which are truly triple negative. We have gone ahead and done a targeted panel. So this panel was a focused exome comprising of more than 5,200 genes, which are clinically relevant and curated in the OMIM database. We, instead of doing the regular 80 to 100x depth that is required for a germline listing, we went ahead and done at a greater depth of 250x on Illumina HiSeq platform. This is a representation of the filtering process that we have done. So what did we get? Triple negative ET. Around 47% of these cases had evidence of clonality in terms of likely pathogenic, or the VUS variants. And as you can see, highlighted are the MPL and JAK2, which are non-canonical and novel mutations. In like how previously it was reported, we also found that these variants were non-canonical. And the mutations in other non-driver genes included SRSF2, EZH2, etc. And other pathogenic mutations were reported in NOTCH1, ATM, etc. In triple negative PMF, 39% had evidence of clonality with regards to these pathogenic and likely pathogenic mutations. MPL, 4 patients had MPL mutations. Most of them were non-canonical, except one was an indel in 515. This could not be picked up by allele-specific PCR because of the complex nature of the type of mutation that there was. The other mutations included TET2, ASXL, EZH2. The remaining were this whole list of genes that you can see here: CBL, FLT3, MPIG6B, KRAS, etc. Only one patient had a copy number large deletion in EZH2. How did this exercise help? Not only in identifying the clonality in 2 patients of triple negative PMF, we could identify the high molecular risk markers that is important in prognosticating them. In MP and U group, 6 patients had 4 patients had ASXL, TET2, etc. Basically, telling that there was clonality in these patients. This is overall representation of all the cases that we have studied, showing that various genes, all the genes that were mutated. However, there was not a significant co-occurring mutation here. One interesting case I would like to present here was that of a 14-year-old girl with anemia, splenomegaly, who was diagnosed with PMF. These are the pictures from her bone marrow biopsy that clearly shows the hypercellularity, then intrasinusoidal hematopoiesis, abnormal megakaryocytes, and moderate to marked reticulin here, that is the fibrosis. And in this child, we identified a novel homozygous mutation in the MPIG6B. MPIG6B is basically a megakaryocyte platelet inhibitory receptor present on the platelets. And this is a splice site mutation, and this is associated with a phenotype of thrombocytopenia, anemia, and myelofibrosis. Now, this is electrophyogram showing the homozygous mutation in the child and the mother. Unfortunately, father is not available to complete the pedigree here. And we did sequencing of the cDNA, which shows the retained intron. Although we could not prove the functionality of this splice site, we stopped at predicting the functionality by showing this inserted intron could result in the presence of an active site. So basically, to summarize that, the current hematopathologic diagnosis relies heavily on molecular cytogenetic analysis for diagnosis, prognostication, selection, and monitoring of therapies. This reliance will only continue to expand. As you can see, that a lot of genomic studies are in progress, and with each classification, you have a list of whole new entities that are being added on that will help us in diagnosing. Although this is there, NGS does not replace the conventional diagnostic workup that includes astute clinical judgment, basic CBC, peripheral smear, bone marrow examination. With regards to triple negative entity per se, whole exome or a targeted exome sequencing helps in identifying possible etiology in this group. Thank you.